Thank you. Forgive me for my tear. My flight was delayed. I had to reroute in Frankfurt. I came 7 hours late without my luggage. So this is my tear. And of course, stores are closed on Sunday in Spain. Okay. So who are clinicians that treat patients with coronary artery disease? Okay. So the question, do we really need aspirin loading for STEMI? This is my main topic, but I'll touch other things. So aspirin for primary prevention. So we all grew up that everyone after the age of 45 should get on aspirin for primary prevention. We thought that we have great data to support it, but actually, if you go back to the old data, it is unclear. None of the studies showed reduced mortality. They show reduction of myocardial infarction with excess of bleeding, but not effect on mortality. And overall, interpreting the old classical data said, you can wait, because we believe that aspirin is good for secondary prevention. You can wait until you have first event and then start the aspirin. But 3 recent placebo-controlled trial of aspirin, 100 milligram, ARRIVE, ASPRI, and ASCENT have failed to show superiority of aspirin over placebo in reducing the rate of the composite endpoint while having shown an increased risk of bleeding. So those are the 3 reference if someone needed. There is this meta-analysis by Salim Virani that worked at, Baylor College of Medicine. Aspirin with and without statin in individual without atherosclerosis, cardiovascular disease across risk categories. That overall, aspirin seems to be better. Do I have a light? No. However, aspirin also significantly increased the risk of bleeding. And they concluded that in adults without atherosclerosis cardiovascular disease, concomitant statins appear to significantly reduce the absolute risk reduction for myocardial infarction associated with aspirin without influencing bleeding risk. The anticipated absolute risk of major bleeding with aspirin exceed the absolute MI benefits for every level of atherosclerosis cardiovascular disease. So I was interested in this meta-analysis because in my animal study, I showed an interaction between aspirin and statins. Actually, aspirin blocks a lot of the pleiotropic effect of statin, including myocardial infarct and even in atherosclerosis, but patients are not rats or mice. So you have to further investigate it. In 2022, the US Preventive Services Task Force recommended to use aspirin for primary prevention in patients between the age of 40 to 59 years old who have a 10% or greater risk of 10 years cardiovascular rate and who are not at increased risk of bleeding. It is also recommended against routine use of aspirin in patients older than 60 years of age. So cutting a lot of the recommendation for aspirin prevention. Now, this is another recent paper in 2023, P2Y12 inhibitor or aspirin monotherapy for secondary prevention of coronary artery disease. So they took patients 3 months after dual antiplatelet therapy, after PCI, and so forth, and run and combined them and looked on outcome. So as we can see, to go back. Actually, the P2Y12 inhibitor looked better in both clinical outcome and on bleeding. Here, B. So now, even for secondary prevention, we are getting into the notion that P2Y12 inhibitor, clopidogrel, ticagrelor, prasugrel, but mainly this is not shortly after PCI, clopidogrel is safer from bleeding point than aspirin and maybe more efficacious on the clinical outcome. So this is net adverse clinical events favoring P2Y12 inhibitors. And if we look on the individual endpoint, okay. Cardiovascular death, MI or stroke, better with a P2Y12 inhibitors. Bleeding, yeah, oh, yeah, it's very weak. Okay. And so it's hardly seen, but bleeding seems to be better with P2Y12 inhibitors. So the ACC-AHA guidelines for the management of patients with ST elevation myocardial infarction write class 1 indication. Aspirin should be chewed by patients who have not taken aspirin before presentation with STEMI. The initial dose should be 162 milligram, level of evidence A, to 325, level of evidence C. Although some trials have used enteric-coated aspirin for initial dosing, more rapid buccal absorption occurs with non-enteric-coated aspirin. And we know this is quality assurance that everyone with chest pain should get aspirin within 10 minutes of arrival to the emergency department. What is the basis? And they continue to say, unlike fibrinolytic agents, there is little evidence for the time-dependent effect of aspirin on early mortality. However, data do support the contention that a chewable aspirin is absorbed more quickly than one swallowed in the early hours after infarction, particularly after opioid therapy that delayed gastric emptying. This is a small letter in the text that most of us don't have time to read on the guideline. The European guideline for the management of acute myocardial infarction in patients with ST elevation myocardial infarction say the same. Aspirin should preferentially be given orally, 150 to 300, including chewing, to ensure complete inhibition of thromboxane-dependent platelet aggregation, but may be given intravenously in patients who are unable to swallow. Convincing evidence of the effectiveness of aspirin in addition to fibrinolysis was demonstrated by ICIS-2 trial, in which the benefit of aspirin and streptokinase were seen to be additive. So what is the ICIS-2 trial? We'll go there. The 2013 ACC-AHA guideline for the management of ST elevation MI, emergency medicine dispatcher are trained to instruct patients with possible STEMI symptom to chew non-enteric-coated aspirin, 162 to 325, unless contraindication, while personnel are en route to the hospital. So antiplatelet therapy to support PCI for STEMI recommended class 1, aspirin 162 to 325 should be given before PCI. After PCI, aspirin should be continued indefinitely, level of evidence A. This is the European aspirin Before procedure, class 1. Maintenance dose, class 1. 81 is a preferred maintenance dose. No, this is American. So adjunctive antithrombotic therapy to support perfusion with fibrinolysis, again, aspirin loading and aspirin maintenance. And 81 is, so we have repeat recommendation from the guidelines to use aspirin chewable as early as possible and maintenance dose. This is a European guideline. Aspirin is recommended as soon as possible for all patients without contraindication. For patients receiving fibrinolytic therapy, the first dose of aspirin should be chewed or given IV, and a low dose given orally thereafter. So all are coming from the ISIS-2 trial that was published in 1988. Many years ago, in this trial, 17,000 patients within 24 hours, median 5 hours after the onset of suspected myocardial infarction, not STEMI, were randomized to streptokinase, 1 month of enteric-coated aspirin, 162, both treatment, no treatment. The primary endpoint was 5 weeks vascular mortality. Now, the aspirin was enteric-coated, not as the guidelines now say. Later on, small studies suggested the absorption of simple aspirin, not enteric-coated, is faster, but we don't have outcome. So this trial was a major success. Streptokinase reduced mortality, 5 weeks mortality. Aspirin had similar effect on mortality, and the combination was additive. The only problem here that the chewable part of aspirin was not separated from the maintenance dose. So we actually don't know if we need the chewable aspirin because it was not tested. Theoretically, it can be that the 4 weeks of oral aspirin did the job. We know the same for clopidogrel, that it doesn't start acting before the PCI, yet it is working. So the question is how aspirin work and where? And we don't know. What we know that at the dose of 81 milligram, aspirin had no antipyretic or analgesic effect. It does not cross the liver. And this is a very old study from 1985 that says, in fact, different pharmaceutical formulation of aspirin may deliver little or no aspirin to the systemic blood. This was the case, for instance, in healthy volunteer taking 320 milligram of compressed aspirin or 800 milligram aspirin. In all instances, thromboxane B2 generation in serum was fully inhibited. So they thought, it's hypothesis that has never been fully proven, that the aspirin works in the portal circulation between the gut and the liver. There it inhibits the platelets, then the aspirin gets to the liver, they are acetylated, and not a lot is getting out, at least in the small doses, which means that there is a major difference, theoretically, between chewable aspirin that is supposed to be absorbed by the buccal mucosa and bypass the liver, and the ones that we are chewing, swallowing. So here we did a paper that was published in 2008, and we looked on the infarct size limiting effect of 3 days of atorvastatin in rats. 3-day pre-treatment reduced infarct size in the wild type mice, but not in enos knocked out mice and inos knocked out mice. And we postulated the mechanism that the statins activate COX-2, and this COX-2 generates prostaglandin that mediates the protection. So we showed that aspirin blocks the protective effect. I'll show you the slide. However, this was not replicated in humans. Effects of high-dose atorvastatin pretreatment in patients with ST segment myocardial infarction undergoing primary PCI, a CMR. Patients that underwent primary PCI for STEMI within 12 hours after symptoms were randomized to atorvastatin 80 milligram before PCI and 5 days later, or control. All patients received 300 milligram of aspirin and 600 milligram of clopidogrel before PCI. And the trial was completely negative. Now, there are a lot of explanation why statins reduce infarct size in small animals and even in dogs, but not in the clinical setting. The myocardial infarction in the clinical setting is because of thrombus inside the coronary in animal model, you ligate the artery and so forth. Yet, I'm the only one that talk about the effect of aspirin. Because in those clinical trials, all patients received chewable aspirin, loading. The same is efficacy of early intensive rosuvastatin therapy in patients with ST segment elevation myocardial infarction. 185 patients were assigned either to early high dose of rosuvastatin or to conventional low dose rosuvastatin, 10 milligrams for 7 days. All patients received aspirin 250 and clopidogrel before PCI. Again, the trial was completely negative. So here we looked on aspirin before reperfusion, blunt the infarct size limiting effect of aspirin in rat. So aspirin 20 milligram does not affect infarct size. Atorvastatin reduce infarct size. All rat exposed to 30 minutes of coronary artery occlusion and 24 hours of 4 hours of reperfusion. As we see, and we add aspirin 5, 10, 20 before reperfusion, we block the protective effect. Now, if we gave aspirin at occlusion, like when we give it in the ambulance before coming to the hospital, the protective effect was lost. This is atorvastatin alone. If we gave it after reperfusion, atorvastatin reduced infarct size. Now, this is another paper. Chronic treatment with ticagrelor limit myocardial infarct size dependent on adenosine release, followed downstream with COX-2 activation. So ticagrelor reduce infarct size, clopidogrel that does not affect the adenosine has no effect. And when you block with CGS, the adenosine, you block the effect. Ticagrelor reduces infarct size, but when you combine it with low-dose aspirin, the effect is not blocked. 10 milligram, 25 milligram, the effect is lost. And here we showed that COX-1 inhibitor did not block it, but COX-2 inhibitor blocked it. This paper, when we published, came right on time because it was the result of the Plato trial and the question of the dose of aspirin. Because ticagrelor did not reduce the outcome in the North American patient, and retrospective study came out and said that it is because of the maintenance dose of aspirin that was 325 in the US, and in the rest of the world was lower. And since then, the guidelines say that if you're using ticagrelor, you should use 100 milligram aspirin or lower. But remember that we continue to give loading dose of aspirin, 325 at least, chewable, or in Europe also IV, initially. And it might be that this dose blocks the protective effect. It might be. I don't have a proof because we didn't do it in the clinical setting. Ticagrelor versus clopidogrel in patients with acute coronary syndrome. This is what I said, that the original Plato that was published in 2009 showed that in Europe, Middle East, and Africa, it reduced, but not North America. And this is a retrospective analysis from 2013 that showed that if you have high dose of aspirin, you have more endpoint than ticagrelor with low dose of aspirin. But this is only on the maintenance dose, not on the initial dose. Now, if ticagrelor was so potent to reduce infarct size, they tried to do the Atlantic trial to see if you give ticagrelor pre-hospital, if you reduce clinical outcome. So patients were randomized to receive either pre-hospital in the ambulance or in hospital in the catheterization laboratory treatment with ticagrelor in addition to aspirin and standard of care. So overall, the trial was negative on the composite endpoint. As you can see, the p-value, absence of ST segment elevation occur a little bit less in the pre-hospital, but it was not a major success. Death from any cause, pre-hospital 3.3%, in-hospital ticagrelor 2%. Something was wrong. So it might be that the time that they gave it pre-hospital was only on the median 32 minutes earlier. And then there was maybe interaction with opioids the patient got and delayed gastric emptying. But it might be that it is because in the clinical setting, we give aspirin loading that blocks the pleiotropic effect of ticagrelor. Now, ischemic post-conditioning, started reperfusion, reduced infarct size in animals. In the clinical setting, it doesn't work. In the Dynamite 3 IPOS trial, routine post-conditioning in addition to primary PCI failed to reduce the primary composite outcome of all-cause death and hospitalization for heart failure. Whether post-conditioning may offer cardioprotective in an enriched STEMI population remain unknown. Lack of effect on infarct size following primary percutaneous coronary intervention. We did a small study in animal in rats. So we did post-conditioning after 30 minutes of ischemia with and without aspirin. So if we look on infarct size, post-conditioning reduced infarct size in the animal, but when they got aspirin, the protective effect was blocked. And there is also the story about morphine. In animal studies, morphine is protective through the delta opioid receptors. While in the clinical studies, we have an impression that people that got morphine having worse prognosis, and it might be a bias because maybe patients that get morphine are sicker and have more ongoing pain than people that do not get morphine. Those are not prospective trials. But there is one study also showed that if you give aspirin, you block the protective effect of morphine. So do we need rapid onset of antiplatelet drug? And if so, can it be achieved with other agents? And we had this lesson with the 2B3A inhibitors. The 2B3A inhibitors giving IV, integralin, tirofiban, and Riopro, supposed to block the platelet completely. The final common pathway of platelet activation. They are giving IV, rapid onset of action, and when they came out 30 years ago, we thought that they are miracles. But later on, we learned that when we use clopidogrel, that is oral, pro-drug, need to be activated, takes time, the effect was lost. And now we hardly use 2B3 inhibitors at all. So the question is, when do we need the potent antiplatelet? Immediately before a perfusion, at reperfusion, or half an hour, 1 hour, 2 hours later, when the inflammatory process start, edema start, and so forth, what we call reperfusion injury. It is not settled, and I wrote an editorial, a review on it also. Does aspirin have other unique property besides its antiplatelet effect? Is it so magical, or can we achieve it by other means? Can it be that by using other antiplatelet agents that do not block COX-2, we might be able to benefit from the agent procedure like ticagrelor and statins and post-conditioning that protects against reperfusion injury, at least in small animals? So I think now time comes. Until now, we believe that aspirin is magical and we need to use it. Now is no longer indicated for primary prevention for everybody. Now we are switching from aspirin to clopidogrel for stable patients at increased risk of bleeding. We are shortening the time of dual antiplatelet agent more and more, and are showing that it is safe and beneficial, with a trend to continue with clopidogrel rather than continue with aspirin. But this part, the initial treatment of patient with ST segment elevation myocardial infarction, is still considered holy. So I published this review, do we still really need aspirin loading for STEMI, in 2022 in Cardiovascular Drug and Therapy. And activation of COX-2 is essential for mediating protection. When we give aspirin, We block not only COX-1, but we block COX-2, and therefore we block a lot of the preconditioning effects. So, oxygen. For years, we thought that oxygen is essential for everyone with chest pain. We see it in every movie. Yet, the guidelines say oxygen is indicated in patients with hypoxia, but routine oxygen is not recommended in patients with saturation above 90. We are changing. The one of you maybe still remember that many years ago, every patient with myocardial infarction was placed on lidocaine drip. We no longer do it. We change our practices a lot, and it might be that now is the time to change the practice with aspirin. But of course, I brought you hypothesis and observation. They should be explored in the right clinical setting. Thank you.